Association and the Dell Medical Students Integrative Medicine Interest Group. Welcome to Allopathic and Traditional Chinese Medicine Approaches to COVID-19 Patient Care. Just a couple of housekeeping items before we begin. Number one, if you can make sure you're on mute so that we can really hear the important information that's coming. Number two, we are going to be recording. So generally this speaker or any slides or anything are what you will see on the recording, but your little picture might show up in the square. So if you prefer to have your video off, feel free to do that. But we might be allowing others to watch this later that couldn't make it this evening. And number three, we're going to have a format of 20 minutes of allopathic medicine talk, then 20 minutes of traditional Chinese medicine talk. And then we're going to have time for questions and answers at the end. We have two options for that. If you think of something while they're talking and want to type it into the chat, we can make sure that those questions are asked, or you can wait until the end. And if there's time, you can just ask a question yourself. So whatever you're comfortable with. So welcome. I'm going to start with Karina, who's going to introduce our first speakers.
Thank you. So we have two professors from Dell Medical School here today. So I just want to introduce you to them for those AOMA students who may not be familiar with who they are. Dr. Ernestine Lee is an assistant professor in the Department of Population Health and associate program director of the Family Medicine Residency at Dell Med. She received her MD and MPH from the University of South Florida and completed residency in family medicine at the University of Florida. Dr. Lee practices as a family medicine physician right now. And Dr. Kumar Pandian is an assistant professor in the Department of Internal Medicine at Dell Med. Dr. Pandian received his MD from the University of Minnesota and completed residency in internal medicine and pediatrics at Indiana University. He practices internal medicine at Dell Hospital in Austin. So thank you both for being here. And let's see, do we want to introduce Dr. Shen right now too?
Yes, I can go ahead and introduce.
Okay, thank you.
Okay. So Dr. Shen has taught acupuncture and herbal medicine at two colleges in China and was a traditional Chinese medicine physician at the teaching hospital of Chengdu College of Medical Continuing Education. He teaches acupuncture and herbal medicine at AOMA while also supervising clinic shifts. In addition to contributing to various professional journals, he is also a frequent presenter at national conferences on topics such as the use of traditional Chinese medicine in treating patients with multiple sclerosis, hepatitis, and diabetes, and on the interactions between Chinese herbs and pharmaceuticals. Dr. Shen served as Director of Clinical Studies at AOMA from 2003 to 2010, and he has been a member of the faculty at AOMA since 1999.
Thank you. So if I think we're going to begin with Dr. Pandian and Dr. Lee. And
also one thing in common between me and Dr. Pandian, I'm sorry for the interruption, is that I also have a MPH, public health degree. So we can share some common language in that area too.
Wonderful, thank you. So whenever y'all are ready, feel free to share your screen and we'll get started.
Sure. So I think, so we put our presentations together and I'm gonna go ahead and start here. Let me see. Okay, so, all right, we just have a timer here just to make sure I don't go over time. All right, so yeah, well, thank you very much for the introduction. Thank you for the opportunity to talk to everyone. Again, this is going to be an interactive session, so we'll kind of go through our sort of material. But if you have people have any questions, feel free to chime in. So, so I'm as Karina had said, like I'm with the departments of internal medicine. I'm also with pediatrics. I see both patients at Dell Children's and at Dell Seton. So let's see. I think, okay, you guys can see my screen, right? So let me, oh, there you go, okay, good. So the objectives of the talk today, basically talk about COVID epidemiology and pathophysiology, the outpatient evaluation management, inpatient evaluation management, and then, so we'll go, we might have time to go over the vaccinations, but we'll kind of table that at the moment. So just a quick thing, COVID is a coronavirus disease. COVID-19 is actually the disease. The virus is the SARS-CoV-2 virus. So people use them interchangeably. I do too sometimes, but just to recognize this, both of those are a little different. And it's coronavirus just as a little trivia thing, because if you look at it in the microscope, the virus looks like it's a crown. So it's a coronavirus.
Mm.
All right. And I don't know if you guys have the SARS epidemic from 2003. If I see some young faces over there, if people remember from a long time ago, the SARS outbreak back in 2003, and MERS, which is the Middle East respiratory syndrome, Middle East respiratory distress syndrome, they were all related. They're all coronaviruses, and so and they're all from zoonotic vectors. So the presumption is that all these three viruses came from bat initially, and made their way to humans through different animals. MERS was through camels, and SARS, the original outbreak with the different virus, was through civet cats, and I think this pandemic is thought to be through pangolin as the intermediary host. So, and just so you guys know, like MERS is still active in the sense that there are still cases on a yearly basis in the Middle East. There's a proportion of camels that still carry the virus and still transmit to humans. So it's still around. And it has a pretty high mortality. All right, that's kind of the history behind it. There are different coronaviruses that are still present here, like everywhere around the world, that cause disease, but not this particular syndrome. And so coronavirus exist in human sort of disease and cause disease. So these are numbers I pulled this morning. Basically, the number of cases across the world is 112 million, with about almost 2.5 million deaths. United States is about 500,000, and you guys probably heard it in the news about the milestone, unfortunately. And if you look at the numbers here, like the second largest number of infections cases in India, but you look at the mortality, it's much different. And so I think there's unknown in terms of why there's that discrepancy, but you can kind of see the discrepancy between the number of cases and the deaths. And just a little kind of a tidbit, the number of cases in kids, mortality is pretty low. And kids do get the virus, and not infrequently or symptomatic, but not as much as adults are. All right, transmission is airborne and droplet, much less contact with surfaces than we initially had thought. And so, but airborne is kind of the biggest thing. And that's why masks really are important in controlling spread from person to person. Just a quick thing about how the virus actually acts, and this has ramifications for how we end up managing it. So you can see that there's the virus here. These are the spike proteins, and these proteins are attached to what's called ACE2 inhibitors on the cell, human cells. And this is the attachment point. Without a working mechanism, this will not attach to humans and infect humans, right? So this spike protein attached to humans gets inside the human cell over here, and then that's where it replicates and then kills essentially the cell, and then replicates, and you have more viruses. And so this entry point is the key, because once it enters the cell, it basically destroys the cell, or at least damages the cell, sets off a huge inflammation, which causes the disease itself. You'll see this graphic a couple times throughout our presentation. Basically, this was put together by Dr. Broad, who's one of our hospitals at Dell, and kind of goes through different phases. I mean, there's three major phases to this condition, this infection. The first phase is the early phase, where it's primarily viral. The virus is replicating like crazy, and so you have all these mild symptoms, and I say mild because it could get a lot worse, right? So when you have the symptoms of flu-like symptoms or the cold and stuff, this is what's happening, is the virus is replicating in the body, spreading throughout the body, and causing some inflammation. As time progresses, you can see kind of down here, as time progresses, people actually get sicker. If they're going to get sicker, they actually get, if they worsen, they actually get worse about a week into their illness. Most viruses cause like illnesses probably in 3 or 4 days, and by day 7 they're improving. But here they actually get worse, if they're going to get worse, about a week in. And actually, then it progresses. If they're going to get worse, it progresses on. And about 3 weeks into the illness, on average, is when we see people die. So when people get admitted, when you see a surge, like any place, like we had a surge in Austin, back in January, right after the holidays and stuff like that, that surge was then preceded by people dying 2 or 3 weeks later. And so anytime you see that surge, that the people, hospitals may get less full, but people are dying at that's when they're at that time. So anyway, it's kind of an overall big picture thing. You have the early infection, symptomatic, if you're going to have symptoms, and then you have the lung phase, and then you have this sort of the phase where people actually end up dying at that time. So risk factors, as you guys probably know, older age groups, people with lung disease, people with heart disease, diabetes, and people who are overweight or obese are at much higher risk. It causes a whole bunch of different pathologies and symptoms all throughout the body. We'll kind of highlight that a little bit later on. But primarily, what we like a lot of you guys know is the loss of smell, anosmia, loss of taste, and then you have people with strokes, and of course the lung injury. So these are other outside of the lung injury manifestations. So it can be quite systemic. So good. All right. So, and I'm going to turn over to Dr. Lee to talk about the outpatient management.
Great. Thank you, Dr. Pandian. Will I be, oh, great. Okay, thank you. Yeah. As you can see from that slide that Dr. Pandian shared, I really think that's a great summary of the progress of the disease. And so we're going to show that slide again. But on the outpatient side, there are a few things that we can do, but like things like influenza and other respiratory viruses, although we know SARS-CoV-2, as you can see from that previous slide, causes much more systemic pathology, particularly in that thrombotic phase, the last phase there.
Sorry.
That's okay. No, I think it's good to refer back to that. So, this day, let's cancel. So on the bottom here, 0 to 6, those are oftentimes the times that people come into the clinic. Perhaps they maybe lost their sense of taste or smell. And so the majority of people, thankfully, don't go on to be hospitalized. So in the outpatient side, though, I think it's important to know sort of what our triggers are to perhaps sending people to the hospital. And then what are some of the things we can do without the patient being admitted to the hospital. So as you can see on the top of the slide there with the treatment, so usually remdesivir and convalescent plasma are still going to be reserved for those patients in the hospital. However, we do have in Austin access to monoclonal antibodies, even for people with mild to moderate disease who are not admitted to the hospital, but meet certain high-risk criteria. So the example of being over 65, having a BMI of greater than 30. So BMI 25 to 29.5 is overweight, and then a BMI of 30 or more is considered obese. And we know that obesity is a pretty big risk factor. That's okay. A pretty big risk factor for more severe disease. But really, in general, the first phase, if someone comes into the clinic and we do a swab and we diagnose them with having coronavirus, we of course educate them on preventing further spread. So, most public health measures, as we've learned from the pandemic, they're not super exciting, but they're so important. So, simply wearing a mask, and then the difference between isolation and quarantine. So isolation is when a person has been diagnosed and they want to be isolated from every other person in the household, which, as you can imagine, for patients with limited resources, that can be very challenging. Or if you have an adult who's the caregiver and they're the person that needs to isolate. So this is a very challenging situation for many of our patients. But again, isolation is the terminology we use for the person who is ill. And then quarantine is if you've been exposed. So if you've been in close contact, so more than 15 minutes without a mask or adequate PPE, that would be considered a high risk contact. And so that's when we quote quarantine people in their home, so they can kind of go about their home, but they should be careful, they should be cautious, they should wear a mask around other people who are not ill. Just, I think sometimes those terms get used interchangeably. And again, there is the difference: isolations for the sick patient and then quarantines for the person that is exposed. And again, a high risk exposure is greater than 15 minutes without adequate PPE, particularly a mask. When we do diagnose patients in the clinic, we do have at community care, or where I do my outpatient clinical practice, we do have pulse oximeters that we can give to patients with instructions. We can ask them to at least check that 3 times a day. And if their pulse oximetry numbers are starting to drop below 92, we do recommend that those patients go to the hospital. And going back to that slide, the concern is that those patients might be going into the ARDS, or the lung injury phase. And we know at that point, they might be a good candidate for dexamethasone. The studies involving dexamethasone did show a lot of benefit. So giving those patients that advice to go to the hospital when they potentially are moving into that lung injury phase is really important. So again, it's a very simple device. It's not anything super exciting or cutting edge, but it can be really helpful to send the right patients to the hospital at the right time. Of course, we always tell patients, if they're at all feeling, significantly more short of breath, their symptoms are at all worsening, particularly if their symptoms are worsening around day 7 to 10, because we know by day 7 to 10, if they're going to be getting better, they will be getting better. But if they're getting worse at day 7 to 10, then it does concern me that they're moving into that, ARDS lung injury phase and need to get treatment at the hospital. It's really important to note that the studies involving dexamethasone were not for stable, mild to moderate disease patients. So we do not give dexamethasone to patients on the outpatient side. That's reserved for patients who are requiring oxygen, that are in the hospital. So that is not a non-hospital treatment. Lastly, of course, we do have the Regeneron, and we call it BAM because a lot of us can't say bamlanivimab. So those are the 2 antibodies. Again, these are reserved for high-risk patients, but they can be outpatients. So there are several centers in Austin that we can refer patients to get this. It's best if we get it to the patient within 7 days of their symptoms starting. And again, thinking about that phases of disease infographic that we shared, that really makes sense. Because if they're moving into day 7 or 10 and are getting worse, we're kind of past the benefit of Regeneron or bamlanivimab. So Regeneron is often called Regeneron. That's actually the company that makes the antibody. It's 2 antibodies, casirivimab and imdivimab. Say that 5 times fast. And so those are 2 antibodies that sort of neutralize the virus. And then the Lilly COVID antibody is the bamlanivimab. And there are some studies, I don't have all the data on this yet, but some new recommendations may come out to say to give both of these, to give it as like a quote antibody cocktail. But as far as I know in Austin, I don't know if we're doing that yet. So again, just to reiterate, it's really important, the phases of disease. By day 7 to 10, if patients are getting better, they probably are going to continue to get better. By day 7 to 10, if they're worsening, if they're dropping their oxygen stats, and they really need to get to the hospital for that dexamethasone and further oxygen support. Next slide. And so again, reminding us of that infographic, I just think that really helps me understand the phases of the disease so well. I just keep it in my brain. So we bring it up a couple of times. So many thanks to Dr. Broad, one of the hospitalists at Bellmed, for creating this. And thank you, Dr. Pandian, for putting it in the presentation. Next slide. So I wanted to give you all some, I know the integrative, our integrative medicine colleagues are going to speak on this a bit, but as I was looking into the literature, the other question that's coming up are patients who are suffering from long-term sequelae of COVID, and some of the terminology that's been used for that is long COVID or long haul COVID. And really that can impact patients, even if they just have I don't want to say just because coronavirus is pretty severe, can be pretty severe, but for some patients, it might still be called mild. But those folks can still have these long-term symptoms. And so was a really great publication, actually. It was just published December of 2020 by the group out at the University of Arizona College of Medicine with Dr. Weil and his center there. So it's a really great reference. And the next slide here, I believe, has kind of a summary of some of the treatments. So I know this doesn't copy very well, but I encourage you guys, I do believe we have the references listed, but it really gives sort of a great graph here of considerations for those that are convalescing from mild to moderate COVID. So we won't go over these in detail, but I really appreciated this information for myself and what I can recommend to patients going forward. And then I really appreciated the citations that they gave. Next slide. This was another great resource that's available, and there's the link there. We'll certainly be sharing these slides with you guys, I presume. So the Andrew Weil Integrative Medicine Center has a whole web page for integrative approaches to COVID-19. So certainly recommend you guys check that out. Next slide. And this was another great review article. Again, we will include this in the slide. So certainly encourage you guys to look that over as well. Next slide. Great, I'll hand it back over to Dr. Pandian for inpatient.
Okay, thank you. So I'm a hospitalist, so I actually don't see any of the outpatient side. So what I see is basically the patients who are really sick who make it into the hospital. So basically, I'll tell you that the basic management is to treat the low oxygen saturation. So we treat the hypoxemia and the respiratory failure as a number one thing. And then we try to treat and prevent clots, which is the other complication. And we try to treat and prevent organ failure that happens in people who end up continuing to get worse and have complications. And then we monitor for other complications like heart issues, and then monitor for strokes. Oops. Okay, so again, I'm going to go back to this particular slide here. Let me see if I can write on this. So basically, when I see people, it's day 7, like whenever the hospital admission onwards, right? And so what I'm seeing is basically toward the tail end of the viral phase. Now we still have people who are isolated until day 21. If they're really sick that they need to be in the hospital, we don't take them off isolation until 21. Day 21 or so, if they're still doing okay, because at that point I know that there's not active virus in their system. But here at that point we're treating all the other complications that go along with COVID. Primarily ARDS, which is acute respiratory distress syndrome. So I'm going to talk about that in just a little bit. So basically in the hospital, because we're going to be face-to-face with people who are COVID positive, we have to wear sort of full protection, and you can kind of see masks, shields, gowns, gloves, and everything else, right? But that poses lots of challenges because we can't really communicate as effectively with our patients, especially people who don't speak English. And so that's a very big technological challenge and a logistical challenge. It causes patient needs to be delayed. And if someone needs something, then we have to put on all the gear before walking in with everything on hand. So you have to wait for everything to be done before you walk in. So that causes issues. And of course, patients, families and friends can't visit. And that actually causes a severe sort of isolation for patients, like a feeling of isolation, which can be quite problematic actually. So I'm going to talk about the lung injury because this is the #1 cause of death for people with COVID. The lung injury can be very minor. Mild pneumonia that just requires a little bit of oxygen that requires them to be in the hospital, to severe ARDS, which is the respiratory distress syndrome that leads to them being ventilated. The way we treat this is, multiple, right? So if they're just needing a little bit of oxygen, they just get a little bit of oxygen through the nose. That's the primary thing. And then we can actually deliver oxygen through the nose also using a high flow system, which is basically a different contraption that forces a lot more oxygen down, but it's just through a nasal cannula. It just kind of sits right outside. But if they're continuing to get worse, then we have to put them on a ventilator, basically intubation, which is a tube, the tube basically goes down just a regular oral tube. If they're needing a ventilator for more than 21 days, which actually this is quite impressive in the sense that a lot of these people end up requiring intubation for weeks on end. And so those people, we put a tube down, like basically tracheostomy, and down, the bypasses the mouth and then goes straight into the trachea. Oh, I guess the images didn't come through. So, but basically, the lung injury is quite impressive in the sense that people, there's so much inflammation that the airways get plugged up, the small airways get plugged up with the inflammatory material. There's no room for oxygen to come in and out, through the lungs into the bloodstream. So that's what causes people to die. Is at some point, even on the ventilator, we cannot get more oxygen into them. And so anyway, that's the primary thing. But the lung injury is what really gets people, for those people who are going to end up doing worse. So I'm going to go through quickly. So the therapeutics, so what we can do to give them oxygen, primary, we have to give them oxygen. The steroids, as Dr. Lee was saying, is reserved for people who need oxygen. Basically it works by decreasing inflammation. Remdesivir basically is for people who require oxygen also, but what it doesn't really change mortality. It does change the time to recovery, maybe. The World Health Organization actually took it out of their pathway of medications for management. I don't know why oxygen's on. Anticoagulation. So blood clots are a big cause of issues. So anticoagulation is another one of the medications we use. These are other medications that are looked at, but there's not evidence for us to use it. We were using convalescent plasma. We stopped using it for the most part in the hospital, right? Like just recently because there wasn't much data. Ivermectin, if anyone has used it, as an antiparasitic. Again, it doesn't have much data. Colchicine, which is an anti-inflammatory medication, again has poor data. And I'm just going to touch upon hydroxychloroquine because it's been in the news. No benefit, in fact, may have some issues, and so it is recommended not to use. So it is not in the picture of anymore for us. So basically, that's all I had. It's just a quick overview of the therapeutics that we use and what we see with the lung damage. Sorry, I didn't have a picture. The pictures of lung damage is actually quite impressive because it basically kind of fills up the lungs. It's just a whiteout. You can see that there's no oxygen exchange. Okay, well, I'm going to stop right there, and then we can. Do you want to just continue it and then questions at the end, or?
Yes, I think we'll save. If anyone has questions, just hang on to them, and we'll come back to them at the very end.
Okay.
And we'll let Dr. Shen take over. Thank you both very much.
Okay.
Really appreciate it.
Thank you.
Let me see here.
I give all the awesome slides were Dr. Pandian. Like, I feel like we were working on a group project and I gave him something and then he like turned it into this beautiful thing. So I really appreciate that. It's like, I was like the slacker friend working on the group project. So.
It was all preformed templates. I just put stuff in, so.
That was great, thank you.
All right, let me see how I think I can stop sharing, right? How do I stop sharing?
We no longer
You already
see
shared
your
stuff, yeah.
You already did, okay. Excellent.
You already stopped.
Great, okay,
And
very good.
to my thank you very much, Doctors Lee and Pandian. I understand one of you will probably leave a little bit earlier, right? So we don't have a lot of overlaps between my contents and what you have presented. So I don't mind if we right now give them some time to respond to some of the questions the audience might have. Will that work better for you too?
Oh, I have to leave at 8. I don't know, Ernestine would.
What do you guys think?
Yeah, I need to leave at 8 as well, but so just depending on timing.
Okay.
We had one question coming in from one of the Dell Med students who is curious about and I think that's the only question we have so far. Correct me if I'm wrong. If anyone has received another question, please let me know. But the only one that I've gotten personally is for patients who are the long haulers, like what treatment looks like for folks experiencing severe headaches and lack of or anosmia or inability to taste or smell. What does that look like on the outpatient side?
Yeah, that's a really great question. I think some of the research that we can look to, so there is a condition called chronic myalgic encephalitis. It's also sometimes combined with chronic fatigue syndrome. So I think for some long haul patients, we need to look to that research. I think we also are still learning about this virus. So sometimes we don't know what to do, I'll be honest. Like, this is new to a lot of us. And so what we are seeing is that some patients who might have prolonged anosmia or ageusia, they are starting to get some of that back. For those patients that are still really suffering, and so far, thankfully, none of my patients have presented as long haul COVID patients, but I plan to look to the chronic myalgic encephalitis research, which is first in some cases is believed to be post-viral as a start. So I don't have an excellent answer to that question, Dr. Pandian. I don't know if you can add anything to that.
Yeah, no, I don't think anyone knows exactly how the management, but I think I agree. Like the lot of management is symptom care, symptom management, and yeah, the medications. I'm not sure if I'm not sure about the medications. I wonder if you treated like chronic fatigue syndrome type of management, but it's probably multidisciplinary. So
I really appreciated the slide with the Andrew Weil integrative medicine resources on it. I think that's really interesting and helpful. So thank you. I look forward to looking that up too.
Yeah, absolutely. I found it on my literature search today, and I'm looking forward to looking at it myself too. So yeah, we're all learning with each other on this, you know.
Thank you. That's unless anybody has another question, we can probably. Okay, go ahead. Thanks.
Yeah. For COVID survivors who are in the ICU for a period of time, what kind of permanent lung damage is expected? Perhaps most common, least common?
So yeah, I think that data is still sort of evolving, but I'll tell you that there are a couple of things that happen who have been in the ICU really sick. The most common thing is they get this ICU myopathy, where this particular infection is so, like, the patients are so sick that they need to be paralyzed. They need to be in deep sedation, compared to people who otherwise have ARDS, may take like 3 or 4 days. I mean, like I said, like 14 to 21 days or more. You know, we've had patients on a ventilator for a little bit, almost a month, which is pretty much unheard of in other conditions. So when they come out of it, they're extremely weak. You know, I had a couple of guys who were so weak that they were physically not able to like lift their arms to feed themselves. That's not the COVID, it's because of being in the ICU for so long. That takes months to recover from. The physical aspects, the psychological aspects, actually, it's very much like akin to PTSD. People suffer PTSD afterwards, for years afterwards. And actually a significant portion of them, even if they're physically better, they actually are not able to maintain their jobs, relationships. Yeah, so there's a lot of issues that come with it. Like, and then the lung damage, like you're talking about, yes, there's quite a bit of scarring. And a lot of people do recover functionality, but they have long-term chronic scar tissue, which may put them at risk for later on down the road for other insults. And if they get a pneumonia, they have much less reserve than someone who may not have had that scarring. So it's a so.
I actually have a question that I always wanted to ask somebody who worked on the front line of the care for COVID-19, is that what is the situation of the utilization of ECMO in Austin's area? I have not heard people mentioning about ECMO at all, which is very, very commonly used in China in the treatment of this condition.
So yeah, so actually, so at Dell Seton, we don't have the ECMO available. We actually transfer patients over to Seton, Maine for that. And I'm not sure what St. David's Hospital says. And St. David's are Seton eligible to main hospital chains to systems. So it's a very labor intensive process, obviously. And so I think we've only put a few patients, as far as I know, and intensivists may have different numbers. They may have the numbers, but the mortality is pretty high, even with that. So they're very selective in terms of who they will do ECMO on. Usually they're the people who are younger, who have less risk factors that got sick and really sick. And so that's who I've seen being entertained for ECMO. We've sent I think, as far as I know, like 3 patients from Dell Seton over to Seton, Maine for ECMO.
Yeah.
But yeah.
We saw a patient, actually, a COVID survivor, certainly, and actually he had received ECMO. He was a 45-year-old gentleman who had been in the hospital for a month, and as part of his course, received ECMO. And I think, as Dr. Pandian mentioned, we know there's all the comorbidities associated with just being in the ICU and being that sick. So certainly some of the long haul COVID symptoms for those that are hospitalized are going to overlap with a lot of the sequelae of being in the ICU, like the myopathy. There's also something called an ICU neuropathy, where people can get neuropathy almost like a diabetic patient, with like tingling and burning and things like that. So in the more severe COVID patients, there's the concern of long haul COVID, and then there's also just the sequelae of the ICU and that level of acute illness for so long.
I actually have another question. I know I might be having too many questions. When will you consider to start to use steroids or coalition or and first question will be, when will you consider to use anything like steroids or anything to suppress the autoimmune response to the inflammation?
Yeah. So I think Dr. Lee had mentioned, so outpatient, you guys aren't starting steroids, right? And
Yeah.
so, yeah, so inpatient setting, anyone who is requiring oxygen, we do go ahead and start them on it. And the typical duration is 10 days, or if they get, if they stop needing oxygen before 10 days, then we go ahead and stop the steroids. In fact, there's been some data using steroids in patients who are maybe a little bit too long, may actually kind of give you. Well, actually, I take that back. In severe ARDS, then we have to maybe reconsider that. Now the pulmonologists usually kind of make the decision on that, but for the most part, we use steroids. And I think there's some data about people who are not needing oxygen using steroids may be harmful. So, but it's an interesting disease, right? That there's so much inflammation. You would think that controlling the inflammation at the outset would be helpful, but it's actually not the case. So, and I think Dr. Shen, you mentioned something about chelation or?
Oh, anticoagulation. Yes. When will you start to use?
Oh, yeah. So anticoagulation. So we follow the the D-dimer levels. Every patient, every adult and older adolescent who gets admitted for with COVID symptoms, we do put them on prophylactic dose anticoagulation. But if they're D-dimers, and D-dimers are like a byproduct of coagulation, and so if their D-dimers are high, then we go ahead and start them on intermediate dose. Higher than prophylaxis to prevent clots, and lower than a therapeutic that you would use for therapy. If someone does have a clot, at least then we go ahead and start them on full anticoagulation, which is completely anticoagulating them to treat for a clot, even if you don't see a clot.
So when will you start to consider using anticoagulants?
Oh, so the prophylaxis, everyone on admission.
Oh, okay.
To the hospital. Yeah.
Almost immediately.
Yes, yeah. So if they're coming to the hospital being admitted for COVID, then we do go ahead and start them on prophylaxis, unless they already have a clot somewhere, or if their D-dimers are extremely high, then we'll probably start them on a higher dose of anticoagulation. So yeah, so the D-dimer kind of helps us kind of guide that therapy. So yeah, but even through that, people end up having sometimes clots. So and there's some data to suggest that people at high risk, even when they leave the hospital, they're actually being there's some trials going on to continue their anticoagulation after discharge from the hospital. So that data is still out there. If we think that someone's at high risk, we put them on for about 35 to 40 days of anticoagulation at discharge.
Thank you. We really appreciate that. We want to make sure we have time to now dive into traditional Chinese medicine, diagnosis and approach. I know Dr. Shen would continue having this conversation with you all night if possible.
I know. I want to ask a lot of questions. I need to be given the privilege to share the screen.
Sure.
Yes, sorry about that.
No problem.
And again, we are recording this, so those of you that do have to jump off at 8 o'clock, we'll make sure that we have the recording available. And then also we're going to come up with a plan to get these slides available that were so helpful for this evening.
I will keep it short and sweet. One of the reasons I asked questions about the AOMA was because international AOMA meeting was held in Austin area in September of 2019. At that time, I gave them some ride to restaurants, etc. And I said, I have to be very careful. I said, if I, shake with my hands and cause any car accidents, half of the leading pulmonologists in the world is going to have some problems and the world is going to suffer a lot. I said, oh, we're not that important. I said, well, I have a public health background. I know things like SARS we have experienced in China could happen anytime. And we didn't know at that time that was already creeping on us. According to some of the reports that we start to have earlier cases of COVID-19, probably in September or October of 2019. So that was already happening. Some of you have already seen most part of these presentation I've done for some of AOMA students. You can see my slides, right? Oh, I need to go back to the very front. Yeah. Another reason I ask some questions about when you start to use anticoagulants or when you're going to use steroids, because that also help us to explain some of the herbs we're using in the treatment of COVID-19, even from scientific or conventional Western medical perspective. And based upon your answer, I feel more comfortable about our approach of taking care of those conditions because we from our understanding, there's a benefit of using some of those elements in our treatment from the beginning. Let's see. Do you see one slide or two slides? I think you're seeing.
I see two
We're
slides.
seeing the presenter view.
Okay, we're going to switch to the.
There you go.
Okay, got you. So we're going to go through some of those basic slides really quickly. There are some new slides and also have more articles I'd like to share with you all. I'll be able, if I'm allowed to share it in the chat box a little bit later. Those numbers are important in the incubation period. I don't know if you have newer numbers for them, but it's pretty much about the same. That help our outpatient clinicians to make a judgment, the level of risks of those patients presenting our clinic, especially in a clinic that does not focus on the treatment of COVID-19 patients. You will need to know the less risk levels. Both of the doctors have already talked about the pathological changes caused by SARS-CoV-2 to many organs. Also clotting in COVID-19 coronavirus disease. Again, that's one of the reasons that I kept asking when do you start to use anticoagulants in the treatment? According to a lot of relatively recent researches, that there is a lot of damage to the endothelial cells that lines the blood vessels, particularly in the lungs and also in some other organs. That could probably one of the explanations why a lot of those patients suffer from lingering or recurring headaches after the respiratory symptoms or acute COVID-19 symptoms have subsided, because there's a long-term damage to the blood vessels due to the damage to the endothelial cells that lines the blood vessels, etc. That's also very important for us to take into that consideration in our treatment for those conditions. So we add a lot of those herbs that have some anticoagulant functions into the herbal treatment for those patients from very early on. So according to the researchers in UK as well as in North America, they think that a lot of the damages to the organs, including the lungs and kidneys and brains and even some other organs, could be caused by the clogs. Let's see. And also result in stroke. I had a friend telling me that one of his uncles in Colorado didn't have a lot of symptoms of COVID-19, but he very soon had his first stroke in late 40s after COVID-19, and they were wondering if they are related or not. I said it might be related because evidence indicates that healthy blood vessels protect children from serious effects of COVID-19, such as stroke, but that is different for grown-ups, especially for somebody who's in his late 40s, and you don't have the same level of protection that children might have from the severe effects of COVID-19. So, and also both of the two doctors, Dr. Pandian and Dr. Li, have shown a very similar picture to you all multiple times. I want to show this picture to you as well, because I think it's really important for us to understand what we're going to focus on at different stages of the development of COVID-19 disease, even from the traditional Chinese medical perspective. At the very beginning, when the world did not have enough understanding of either the prevention or the treatment of COVID-19 in China, I have been tracking the development of those researches from January 2020, because some of my friends who were pulmonologists in China, they were fighting at the front line against this pandemic. So I did a lot of readings in English research world to help them to also catch up the latest development researches at this time. At the same time, they have to focus on the clinical treatment for the patients who are suffering from COVID-19. I don't want to go very deep into the contents of this slide, since Dr. Pandian and Dr. Li have already talked a lot about the details related to the contents in this slide. What I want to say is that China had SARS in 2003, I think, according to your slide, Dr. Pandian. If I remember correctly, it's probably 2003. For SARS at that time, they found it to be very effective to use steroids as early as possible. So some of them who already went through those, the doctors and the researchers have already participated in the treatment of SARS in 2003, wanted to copy and paste their experience at that time, at the early stage of the response to COVID-19, to treat COVID-19. They found out that that approach didn't work very well. So the early use of steroids really either didn't work or even caused more problems. And some of them later had the hypothesis why it's different. They think that in the pathologic development of COVID-19, most of the symptoms at stage 1, early infection stage, that's probably what Dr. Li will have to deal with in the outpatient department. There are more pathological changes caused by viral response than the autoimmune response or host inflammatory response. And later, after the initial acute stage, the patient will develop a little bit more host inflammatory response. So earlier use of some of those either medications or steroids, other medications to to reduce the inflammatory response was not as effective as SARS in 2003. So from the traditional Chinese medical perspective, at the earlier stage of our treatment for COVID-19, we recommend that you focus on treating the damp heat, especially the heat on the blood level and the chi level. And for our listeners with biomedical background, we're going to give you some of the articles talking about the scientific mechanism of some of the Chinese herbs that will explain my term of heat or damp heat, those kind of conditions. But at the very beginning stage of the treatment, and from both traditional Chinese medicine perspective, even from some of the Western medical perspective, as I'm showing you on this slide, is that we need to focus on the access. We need to focus on the fighting of the virus. But of course, it has a lot of public health impact related to the illness itself and the spill of this disease in our community. Some of you have already seen some of the slides. Let's see, goals for TCM herbal treatment. I think we should probably not be overwhelmingly leaning on herbal medicine or acupuncture for the treatment of COVID-19. If a patient presents with severe symptoms or acute symptoms, I think the first choice is still referring them to the primary care providers, such as Dr. Lee's outpatient clinic, or sometimes you have to be hospitalized. A lot of people are not receiving any active treatment at all. I have a student in my poet education class. There, a couple of months ago, there's one time in my poet education class, I said, "You look pretty tired." And she's a nurse. She said, "Yes, I saw about 20 COVID patients this weekend." I said, "What did you do for them?" She said, "Ask all of them to just go home and quarantine themselves. And if the symptoms develop, they need to go to see their primary care providers or go to emergency room." So, you know, either in China or here in Austin area in the US, a lot of times we decide if a patient's symptoms is too mild, we just, you know, not give the patient any active treatments. Instead, we'll recommend the patient to go home and take care of themselves and isolate themselves. But this is where some herbal medicine or alternative medicine could kick in. You could give the patient some herbal pills, herbal tea, herbal powders to take. You can provide them some counseling, provide them exercises to do dietary therapies to take care of themselves as well. But the reasonable goals for Chinese herbal treatment, at this stage, I don't think you are supposed to treat anybody with acupuncture. That will expose you to a prolonged exposure of the virus. So at the preventive stage, your goal is to improve the immunity and prevent the disease from attacking you. During the symptomatic stage, you want to reduce the patient risk of progressing from a mild to moderate case to a severe to a critical case, and shorten the course of the diseases as well, etc. To decrease the viral load, some of the Chinese herbs have antiviral functions. Again, some of the articles I'm going to provide to you a little bit later will give you a little bit more details about the mechanisms of some of those herbs that have antiviral functions. To alleviate the patient suffering by controlling the symptoms of shortness of breath, coughing, fever, body aches, etc., and treat some psycho-emotional comorbidities too. During the recovery stage, the goal is to restore the patient's energy and immunity and to rebalance the patient's psycho-emotional status. Recently, I have treated quite a few patients who are recovering from COVID-19. Herbal treatment really helped them quite a bit. We can talk about some of those treatment strategies later. But from the diagnostic perspective, traditional Chinese medicine usually considered to be damp heat invasion. let's see, clinical manifestations. We don't have to talk too much about that. There's a similar picture about multiple organ function caused by COVID-19 infections. We don't have to get into the details of those ingredients. This information will be shared with all our audience. So if you want to write a herbal formula for your patient, for those purposes, will be there for you. Let me forward to some other information I think you might be a little bit more interested in. We have multiple herbal formula for your choice. This is a capsule that is considered to be effective for COVID-19 for the mild to moderate, especially mild cases. They have not done enough clinical trials, but they have done some clinical trial laboratory studies. They have found out that the effective ingredients in this product, which is the Pinyin name, or not, which is a Pinyin name. There's no English name of this. Pinyin name of this product. Actually, the active ingredients of this product actually can kill or suppress the COVID-19 virus. That's also the product they used for SARS in 2003. It had been proved to be effective with SARS. And they did a lab study. They found that the active ingredients of this product can also lower the viral load for COVID-19 in mild to moderate cases. But they have not done enough clinical trials to prove that. This is a formula that I have given to some of my patients who have been diagnosed with COVID-19 with symptoms. And after you have suffered from COVID-19, there are a lot of symptoms who are lingering around. And those are the common symptoms from the original attack of COVID-19. And I have an herbal formula for that. I found out actually a lot of my patients don't have enough iron deficiency signs. They have more Qi deficiency signs than iron deficiency signs. So I have made quite a bit of modification to focus on the Qi deficiency signs for a lot of my patients lately who are recovering from COVID-19 attacks. This is another question that some of my patients or my students have asked me about. For the side effects of vaccination, are there any herbs can help with that? So this is the formula that I come up with on the right-hand side. But together, we can definitely win this war against the virus. So that's my short introduction of the TCM approach to the patient care of COVID-19.
Thank you, Dr. Shen.
You're very welcome.
We really appreciate your time. We are going to open it up now for any questions. I actually have one, Dr. Shen. I was on Dr. Chen, who wrote the Herbal Formulas book, did a seminar today talking about the long haulers. And if I remember correctly, he said that it is a lung and spleen, is it yin deficiency, tends to be the common diagnosis for the long haulers. Is that?
That's what I think that's the common understanding, but I'm just saying the patients I have seen who's presenting the symptoms of COVID-19 attack tend to have more Qi deficient signs than yin deficient signs. They don't have a lot of symptoms of dryness or dehydration or body fluid metabolism problems. They have more symptoms of fatigue. Even a lot of them have cognition and memory deficit.
And do you have special treatments for a lot? The brain fog is one of the biggest symptoms. Does your formula kind of cover that, or do you do a formula for that?
I do have a formula for that. Another herbal product called Bunawan could also be effective for that. Bunaowan. So there are some herbal products for those conditions.
Thank you. Anybody else have questions that you would like to ask or also to put into the chat?
Can I ask a quick question and then I have to go? But I just had a quick question for Dr. Shen. Like, what now, do you the herbal medications and so, do you go by their symptoms, or is it sort of a bilateral thing where you actually look at an individual patient's sort of body?
Yeah, I understand.
Body composition, yeah.
We usually have a templated formula for most of the people. For example, I said this is a formula for the acute stage of COVID-19. This is the formula for the recovery stage of COVID-19. That's a formula for the prevention of COVID-19. So we have a templated formula, but we usually will modify those formula based upon the patient individual symptoms. So the herbal treatment we give to the patient are usually individualized, but we do have, because those patients will present some very common characteristics. Therefore, based upon those common clinic characteristics, we do have templated formulas. And the information, the ingredients of those formulas will be shared in my PowerPoint presentation, will be shared with everybody in this meeting.
Great. Well, thank you very much. And I have to run, but thank you very much, Dr. Shen. And I would like to, yeah, I'll get the PowerPoint. I mean, maybe the link to the recording. I'd like to hear and see more about the herbal part of it, because as an allopathic practitioner, it's something that I'm not as familiar with, and I think it would be very helpful for a lot of our patients, I think.
That's right. A lot of herbs we use have antiviral, anti-inflammatory, anti-apoptic, coagulation functions, or those kind of things. And we do have research paper that I can share with everybody.
Great. Be awesome. Okay. Well, thank you very much.
I had a question come in, and also Dr. Pandian, just so you know, this is Dr. Vanya is my spouse here. He took a preventative formula for several months at the beginning of COVID. So even for you, there are great herbal formulas that, especially when you're working during intense times, that really boost your body. I'll say that, your chi and everything, so that and it helps protect you from getting COVID, which is pretty great. I think now you're all vaccinated. He's vaccinated now and isn't taking anything, but he found it really helpful and really felt great on it. So, and I have a question that was written in. How much is understood about the pathogenesis of thrombotic events from both the TCM and biomedical perspectives? I know, Dr. Pandian, you have to leave. Do you have a second to answer that before you go?
Sure. Pathogenesis tell me again, of the TCM?
Yeah. How much is understood about the pathogenesis of thrombotic events from both TCM and biomedical?
Okay. Traditional Chinese. Okay, TCM is okay. I was
sorry.
TCM, yeah, sorry. So I think some of the pathways are understood in terms of how those episodes happen, like how it happens. As to why there's variability from one person to another, that is not as clearly understood, because when you have inflammation in the blood vessels, like Dr. Shen was mentioning, the epithelial lining of the blood vessels, that causes irritation, and that causes a setup for clots to form on that area. Anytime you have irritation of the endothelium of cells or blood vessels, that's what happens. And so that's known. But then why do some people have, certain that, and why do some people don't? So that would be my understanding. Dr. Lee, did you have any thoughts in the?
No, I don't know exactly. We know that the cascade is activated, and certainly once that gets activated, it's sort of an avalanche. Interestingly, when COVID first was, making, on the scene, this wasn't understood, and there was actually a pathologist who has unfortunately since passed away, and I can't remember which institution she was at, but she was one of the seminal people who was doing autopsies on COVID patients who had died, and she was observing all of these clots, and her work actually is what led a lot of physicians and medical systems to start paying attention to the coagulation cascade in COVID patients.
Dr. Shen, do you have anything to add?
Well, I was added from the Western medical perspective about that point is that some of the research suggested that because you have the viral invasion that causes the inflammation, gradually causes the inflammation of the endothelial cells, epithelial cells in the blood vessels. And endothelial cells help to regulate the blood pressure, prevent inflammation, and inhibit clogging, in part through the continual production of nitric oxide. They also serve as gatekeepers for molecules passing through and out of the bloodstream. When injured, they send out a complex array of signals to the immune cells and clotting factors, which rush to repair the site, and they won't follow endothelial cells to be on alert of invaders. So sometimes the over response to that. And everybody's autoimmune response will be slightly different when they respond to the complex array of the signals to the immune cells. So that could probably explain why everybody's response to COVID-19 is different.
Cool. Yeah.
There's another question that's come in about lung repair, and it's actually for Dr. Shen. So I just want to quickly say before I ask the question, thank you to Dr. Pandian and leave. If you all have to leave, totally understand.
All right, thank you very much. And I look forward to, yeah, if you have any questions, Karina, you can feel free to share my email. And so anyone can get in touch with me too, so, okay.
Great.
Thank you.
All right, thank you very much.
Thank you all.
Thank you, Dr. Pandian.
Thank you.
Bye, Dr. Lee.
Bye-bye.
Thank you, Dr. Lee.
So Dr. Shen, there's a question for you that I received in the chat, and it says, would a person utilize, or how would a person utilize traditional Chinese medicine after release from hospital to repair lung damage?
You can take herbs. Generally speaking, there are a lot of formulas can be used to treat the lung damages. Lung damages from the traditional Chinese medical perspective, we would consider to be lung qi deficiency, which usually manifests as shortness of breath, low energy, weak breathing, or lung insufficiency that manifests as hot flashes, dryness, dry cough, or blood stasis in the lungs. That manifests as pains in the lungs and tangible damages in the lung tissues, etc. There are different formulas for those different conditions. I think in the PowerPoint we have some formulas for that, but generally speaking, when you treat the lung damages from the traditional Chinese medicine perspective, you need to nourish lung qi and lung yin at the same time. And that's a question I kept asking Dr. Pandian, when are you going to use coagulants? And I think he echoed my opinion that we need to use it basically at any time. As soon as the patient is admitted to the hospital, he was going to use the anticoagulants. So we're going to use the herbal ingredients that have some anticoagulant functions to move qi and blood in conjunction with the ingredients to nourish lung qi and lung yin. That's it.
Thank you. And I know, just to be mindful of time, it is 8:09, and again, this is being recorded. So if you need to leave, you can always step out, and we'll make sure to put people in touch with the recording.
I can stick around for a little bit longer time if everybody has any questions, but there are going to be a lot of more information for you guys to look at. Let's see.
Yeah, thank you for the links in the chat, Dr. Shen.
I think I probably have a few more. We can give them to you a little bit later. Potential therapeutic effects. That's very interesting how traditional Chinese medicine and conventional Western medicine actually come together, have very, very similar understanding of the pathologic development of the disease and the approaches in the care or case management of COVID-19 patients. So that's pretty neat that you guys, I didn't do a lot, but you guys put all those together to let us look at these COVID-19 health challenges in our community from different perspectives.
Yeah, it's really pretty amazing. It's nice to bring you and Dr. Pandian and Dr. Lee into the same room to have this conversation. It's tempting to almost revisit this topic in 3 to 6 months once we know even more about the disease and about the virus itself. And thank you again for your time, Dr. Shen.
Oh, yeah,
if anyone has any other questions, we're all ears. If not, we will probably wrap it up. And you'll be hearing from us with the PowerPoint.
Robin, I will send my PowerPoint to you.
Okay, thank you. Oh, we have one question.
Yeah.
Sharon, you just have to unmute.
I sent it to Dr. Shen, but very quickly, the pharmacy director at our hospital always recommended a daily irrigant of his nasopharyngeal passages. We always used to kid him about that, but he said, I'm never sick because I do it. Is there any kind of prophylaxis in the realm of this disease that people can, we mask, we cover putting obstructions against our nose and our mouths to prevent intake, but once something's in the nasopharyngeal and mouth, is there anything we can do on a daily basis to cleanse that area other than saline?
That's a very good question, because people also ask me after I received 2 doses of COVID-19 vaccination, do I still have to wear mask and be very vigilant with those conditions? I say yes. One of the reasons you have to still wear your mask is because the virus can still get into the mucous membrane of your nose, and they don't cause any severe symptoms in your system, but you can carry them around and breathe them out and give those viruses to other people. You could do, there in traditional Chinese medicine, there are a couple of things you could do. The most traditional way of doing it that we do herbal steams. The use of herbal steams were a part of the therapeutic approaches in the ancient time, but recent years it has been used a lot in the treatment of nasal allergies as well as for cosmetic therapies, because you can steam not only your nose and your face and reduce the wrinkles and improves the metabolism of cells on your face as well. So there are herbal formulas you could use for the steam. You make an herbal decoction. In Korea, China as well, but mostly in Korea, you have those devices that you could use to actually steam your face, steam your nose. You could just have a little container, have a plastic cover cut out that you can just put your nose or your face into that area that will fit your face shape, and you breathe those steams of the herbal decoctions that will serve the purpose you're talking about. I need to write it down, Sharon. I will give you herbal formula that you can use for that purpose. So that's number one thing you could do. Number two thing you could do is that you could use a Q-tip to dip into the herb decoction and use that to rub your nose as well. That will be very similar to what you have already been doing, but you're going to have a more targeted approach with the ingredients that will work for this condition.
Oh, I look forward to that. That would be great. Thank you.
I'll give that information to Robin, and probably I should incorporate it into the slides so everybody can see that too.
Thank you. Thank you.
I had a question I received. The Tamil Sipa, I do not speak any Indian Peninsula language, so I apologize. The medical tradition of Southern India has been using a 15-ingredient formula, Kabusara, to prevent and treat COVID, especially the loss of taste and smell. Is there anyone in the West who is looking into this formula? The full formula name I have put in the chat. And then here is a list of the 15 ingredients as well, if anyone is interested.
That's nice. I'm going to write down. It won't allow me. I don't think it will allow us to copy. So I'll see if I can do a screenshot. Or you can email to me, Koa. I will be very much interested in this. One of the things we can do in traditional Chinese medicine is treat the impairment of sense of smell and taste will be acupuncture. I found acupuncture to be very effective for that condition. Needling between gallbladder 4 and gallbladder 6, which is scalp acupuncture 9, MS10 is very effective for that condition, in conjunction with some of the other acupuncture points, such as large intestine 4, some stomach points, such as stomach 36, or even some local points around the mouth. But I found the scalp acupuncture threading between gallbladder 4 and gallbladder 6 can be very effective for this condition. But I will definitely try to copy this formula that you have shared with us. Thank you, Kumar.
Dr. Shen, I just took a screenshot and emailed it to you.
I appreciate it.
Do we have any other questions?
I have a question. I'm curious, Dr. Shen, about how TCM relates to and compartmentalizes specifically the loss of taste and smell symptoms that COVID patients report.
We still think at the beginning, COVID-19 is considered to be exterior invasion. When it is exterior invasion, it damages the physiological functions of the organs and tissues on its way in. So it damages the tissues of your nose and the mouth, the cells, the sensory cells and the taste cells in your mouth. So that's the TCM understanding of it, is that it's exterior invasion. It damages the tissues and the cells on its way in.
We could probably take one more question if anyone else has a question before we wrap it up and let Dr. Shen go here.
All right.
All right. Thank you so much, Dr. Shen. We really appreciate
You're very welcome. I appreciate the opportunity.
And we
Thank you for
really
everybody.
enjoy working together, ASA and Dell Medical students. It's been a great collaboration. We're really excited for what's to come. Keep watching. There's more to come. I do believe Karina has tried to rope everybody in for a 3 to 6 month follow-up here. So who knows, maybe we can even get that going. I really appreciate it. We will get this recording together and look forward to connecting again with all of you soon.
Thanks for coming,
Thank you
everybody.
very much, everyone.
Thank you.
Thank you.
Good night, everyone.